All right, I'd like to thank you all for coming here today. I hope it's going to be very educational. My name's Jessica. I've worked with the library here in Covington for 20 years. The main reason I decided to put together this panel for here, bear with me, February 24th of 2017 at about 11 in the morning, I received a call from my mom, and my younger brother, Charlie, had died of a heroin overdose. I had seen many patrons coming in the library. You've seen people going downhill from it. There have been overdoses. We know of overdoses on the street, parents dying, leaving their kids behind. And it wasn't until my 14-year-old niece asked me, why did this happen? My brother's little girl. And I sat there and could not say anything. I'd always considered myself a very intelligent woman, but here I was unable to answer this question. And I think that's really the whole reason the library's always been here, for knowledge and community. And never do we need those things right now more with the heroin crisis going on. The panel today is very distinguished.
So I am a member of the Northern Kentucky community. In about 2012, in a small office in Fort Mitchell, I started noticing notices coming in. People wanted little briefs in the newspaper. When it was, yes, we were online, but print was the biggest deal still at that time. They wanted us to write little notices that they were having vigils for people who had died from heroin overdose. And at that time, I thought, this is very strange. You know, I started noticing the numbers growing, and I thought, general assignment reporters get assignments about anything, but largely we find our own stories. You know, we just are kind of out there. So I decided to make a call to St. Elizabeth and ask if there was a physician or somebody who was also noticing this, and was introduced to Dr. Jeremy Engel, who has been a face of, you know, the front lines of the heroin epidemic, trying to help people. He told me that he had seen 17 patients one day, and he was the on-call for night, and I think it was, he would probably correct me, but at least a third of those patients were somehow connected to heroin, whether it was someone who was addicted or someone whose family member was addicted, someone who was, you know, had been brought in for an overdose. He said they were treating it like bronchitis. Like the ER person would call him, hey, Dr. Engel, blah, blah, what should I do? This happened. And he said, I just can't have that. So that's when I knew I need to really, really dig as deep as I can and really hold on to this part of what I'm going to cover.
Again, my name's Amanda Peters, and I'm with the Heroin Impact Response Task Force, and I'm the coordinator. So I'm tasked with working as a community and government liaison to coordinate and the response between the different systems and players that are in this arena. And I'll just touch a little bit on what some of these folks here, because I know we have the Health Department, Northern Kentucky Drug Strike Force, and Northern Kentucky Hates Heroin here, so we will let them talk about what they're doing. So this task force was formed in 2012. I've only began this work close to a year. My background is social services, workforce development, and community organizing. So where I was not directly into the response work, I was dabbling in it in different arenas. Because what we've learned is that this epidemic touches everything. There's not been a person or an organization or system that this hasn't touched, or I haven't met them yet. So this task force brings together stakeholders from law enforcement, schools, workforce development, reentry teams, social services. Of course, our advocacy and grassroots is very important, but as well as government entities and policymaking avenues. And what we do is we look at a regional approach. So I coordinate the task force for 8 northern Kentucky counties, and that's all the way from Campbell to Carroll. But I'm also working with folks across the river. And this shows Hamilton County, but I coordinate with people all the way up to Highland County and even Claremont County, because we know the folks in Claremont County where they're getting their drugs in Ohio. And by the way, they travel from the 471 loop, is they're ending up in our Newport jails. This is a much bigger problem than just cities or organizations. So I talk to people in Hamilton, and then we're also starting to reach out to people in Indiana.
How do you feel, or is there like a plan to where they don't have to pay for the methadone, or where they, because my other thing is, sorry, excuse me, I used to know somebody who used to abuse their methadone and sell it. So I had called on them once, and they knew I did it. I was very, yes, I did. I'm not going to lie to you. I mean, I'm a very honest person, and they did not like that I did that. So they had to, take it there, I think, for a little while. They did not like that I made them do that. But my thing is, you're getting help, and you're abusing that. Someone else who's doing the right thing, you're abusing the whole thing. Right. So you're going to screw it up for everybody else who's doing the right thing. And I feel that, what would you do, and what's the whole plan for those circumstances, the paying and the abusing of the methadone? I mean,
I'm not a medical professional. I have to say that.
not.
Yes,
Exactly.
I always have to say that. I have to, I dabble in a lot of these worlds just enough to get me in trouble.
Right.
But methadone is very complex. It is a medicine, and lots of medications are abused. So that's going to happen. And we do have, I had my own feelings about methadone, so I went down there and spent a whole day there. I saw moms singing to their children. It was very lighthearted. There was counseling going on. It totally changed my view. And if anybody wants to do that, they're open and give tours. Is it perfect? No. People are going to abuse it. But with medication-assisted treatment, you need the treatment part. If we're just handing out methadone and they're not getting the therapy or the IOP or the treatment they need, it's not going to be effective. It might work for some, but it's not going to work for all. But there are different agencies that will help for pregnant moms. For 1,500 people a day, there's just not enough resources. Right. So getting those folks, some folks are going to be on methadone the rest of their life. Some of them are going to be a year or two. And some people are never going to go back to being the way they were before they used drugs. Their brain has been hijacked. Opiates take away your joy receptors. They're never going to go back to being that. And evidence tells us that they need a whole year of treatment, and that second year to really come out of the fog. This is a long process, and for someone who's dealt with a lot, it takes on a lot. So I'm not sure I can really answer your question, but we are looking at that. We are trying to get the people how to do that. And Kentucky is one of the most regulated states on within methadone, and Medicaid won't pay for it. Yep.
We thank everyone for honoring our work to try to make a difference. I am often asked, how do you do this? Have you taken time to grieve? Maybe you need to take a break. Is it good for you to think about heroin and addiction all the time? The answers to these questions are easy for me. Our son, lived this for half of his short life. Nicholas didn't use heroin for that long, but long enough for it to take his life. He started using marijuana around the age of 15, and this started the path of years of drug use. Nicholas made a choice to use heroin the first time. After that, heroin made choices for him, choices that changed his life like no other drug ever had. Soon after the death of Nicholas, our family hit the pavement running to make a difference in the lives of those suffering from this disease of addiction, and running to help the families like ours that were lost, ashamed, and terrified, helpless, and emotionally broken. My brother Chris approached me before Nicholas's funeral. He told me if I promised not to give up, that he had a plan to help other families going through what we had with Nicholas. Thus, NKY Hates Heroin was born before our son was laid to rest. A lot of things have happened in the past 4.5 years since Nicholas's death. We have been blessed to work side by side with many people that have worked tirelessly to bring awareness, education, and breaking the stigma of this epidemic. Some of those people, my friends, are here with us today. Our family is only a part of a large group. We are not out there alone. We could not and do not fight this fight alone. Through the help and support of donors and volunteers, we have been able to help many organizations such as Transitions, the Brighton Recovery House for Women, Healthy Newborn House, Drogi House, Rap House, Casey's Law, Catholic Children's Home, Northern Kentucky PAR, Grateful Life Center, individuals in need of medical and mental health evaluations. We have purchased and distributed many kits, naloxone kits, to Kentucky and Ohio. We have helped provide financial assistance to those needing transportation to other states for rehab. These are just a few things that NKY Hates Heroin has been able to provide due to the support of those that have faith in our work. We have a lot of events coming up this spring and summer. One of those is our biggest event, our 5K, which is going to be on Saturday, June the 16th. I cannot believe this will be our 5th 5K. This event brings in the funds to help us make a difference in our community for the next year. Our goal this year, we would love to see 2,000 people walking and running in honor of those in recovery and in memory of those we have lost. Please visit our website and our Facebook to see. There's a lot of events coming up. We would love and be honored to see you come and volunteer with us. Without you, we cannot do what we do, what we so desperately need to do. Continue to fight against the disease of addiction. Thank you so much.
So I live in Fort Thomas. When I first moved to work for the Kentucky Enquirer, I moved to Newport, and so I am a member of the Northern Kentucky community. In about 2012, in a small office in Fort Mitchell, I started noticing notices coming in. People wanted little briefs in the newspaper. When it was, yes, we were online, but print was the biggest deal still at that time. They wanted us to write little notices that they were having vigils for people who had died from heroin overdose. And at that time, I thought, this is very strange. You know, I started noticing the numbers growing, and I thought, general assignment reporters get assignments about anything, but largely we find our own stories. You know, we just are kind of out there. So I decided to make a call to St. Elizabeth and ask if there was a physician or somebody who was also noticing this, and was introduced to Dr. Jeremy Engel, who has been a face of, you know, the front lines of the heroin epidemic, trying to help people. He told me that he had seen 17 patients one day, and he was the on-call for night, and I think it was, he would probably correct me, but at least a third of those patients were somehow connected to heroin, whether it was someone who was addicted or someone whose family member was addicted, someone who was, you know, had been brought in for an overdose. He said they were treating it like bronchitis. Like the ER person would call him, hey, Dr. Engel, blah, blah, what should I do? This happened. And he said, I just can't have that. So that's when I knew I need to really, really dig as deep as I can and really hold on to this part of what I'm going to cover. So in that year, St. Elizabeth had turned around 455 overdoses from heroin. There may have been more, in other words, whenever you hear St. Elizabeth numbers, those are just people who acknowledge that they were on heroin. And we thought that was a huge number. So this past year was more than 2,000. You know, I learned that the medical community was fairly divorced of addiction treatment for the longest time. Akron, Ohio is where the AA, the AA treatment came from, and it was working very well for folks who had alcoholism. It was working far less well, although some people, you know, do great with it. It was working far less well among people with opioid addiction. And so, I was fortunate that in 2016, we got an editor whose name was Peter Bhatia. By this time, I was working from the Cincinnati office, but covering both sides of the river, who said, Terry, I see the community response, and I see what this epidemic is still doing and doing, just how much it's grown. Why don't you do this full time? And they sent me off to Baltimore for an American Society of Addiction Medicine conference and a National Press Foundation fellowship, in which I got to talk to people on the front lines on the national level. And I've kept them as my sources, and I've brought back information, and I've tried to cover the various aspects of this epidemic. But primarily, the people who I believe are helping, well, the people I believe are most valuable in my stories are the community members. There was no building to go to when this epidemic started because the government was way behind. We covered, city council meetings and county commissioner meetings, but there was really no location from which we could get the information go out. It depended on people like Holly Specht inviting me into her church first. It depended on people like Dr. Mike Kalfas or Dr. Jeremy Engel asking patients, would you like to talk to someone? Do you want to kind of come out a little bit and show the face of this addiction? And I never pushed anyone to do that, but I can tell you some of the progress we've seen is shown in the fact that these days, and before 7 days of heroin, it was no problem for me to get consent from people. That's because of people like you, Holly. It was no problem and remains no problem for me to get consent for people to have them, to have me and my colleagues tell their story. The reason why that's so very important is because one of the biggest problems with this crisis is stigma, is bias, is discrimination. And we've seen, as much as this is still growing, we've seen progress. We've seen communities come together. We've seen a better understanding of what the treatment needs to be. And we've seen, governments coming together and trying to make a huge difference and making progress. We've seen people who will stand up and say, yeah, I'm addicted to now fentanyl, or I'm addicted to opioids or heroin. And I think that kind of, sadly, that had to come to this, but that may be the most important, what word am I looking for? The most important conduit to saving ourselves from this epidemic.
So I'm tasked with working as a community and government liaison to coordinate and the response between the different systems and players that are in this arena. So I'm going to talk a lot about what we're doing as a community. So this is not by any means my work. This is a compilation of what other people are doing. And I'll just touch a little bit on what some of these folks here, because I know we have the health department, Northern Kentucky Drug Strike Force, and Northern Kentucky Hates Heroin here, so we will let them talk about what they're doing. So this task force was formed in 2012. I've only began this work close to a year. My background is social services, workforce development, and community organizing. So where I was not directly into the response work, I was dabbling in it in different arenas. Because what we've learned is that this epidemic touches everything. There's not been a person or an organization or system that this hasn't touched, or I haven't met them yet. So this task force brings together stakeholders from law enforcement, schools, workforce development, reentry teams, social services. Of course, our advocacy and grassroots is very important, but as well as government entities and policymaking avenues. And what we do is we look at a regional approach. So I coordinate the task force for 8 Northern Kentucky counties, and that's all the way from Campbell to Carroll. But I'm also working with folks across the river. And this shows Hamilton County, but I coordinate with people all the way up to Highland County and even Claremont County, because we know the folks in Claremont County where they're getting their drugs in Ohio. And by the way, they travel from the 471 loop, is they're ending up in our Newport jails. This is a much bigger problem than just cities or organizations. So I talk to people in Hamilton, and then we're also starting to reach out to people in Indiana. That's all right, I don't need it. So this is my mission for the HURT, and we're just to ensure that people of Northern Kentucky have access to life-saving and life-enhancing resources to restore for the community and then to reduce its impact. And there's a framework that we use, and these are our 6 pillars that we use: prevention, treatment, support, harm reduction, supply reduction, and advocacy. Prevention, we're working with a lot of coalitions and also working with schools that are touching the youth. We want to prevent future generations of going down this path. And then treatment, of course, is very important. I don't want to devalue the importance of treatment because we need it and we need the beds. Currently, we have about 43 detox beds and 317 treatment beds in our 8 counties. That is increasing just next week with the Healthy Newborn House, and I don't have those counts yet. And then again in May when we have a treatment facility opening up in Falmouth, and that'll be the first treatment facility, full treatment facility, not just detox, that any of my rural counties is going to have. So it's very important. And those beds don't count our intensive outpatient or outpatient services either. When we talk about support, we're talking about recovery. That's workforce development, housing, life skills, all those things that we need to be self-sufficient. They're all tied together. And what we're trying to do is not create new services, but to drive people to the existing resources in our community. There's experts that have been doing these for 50 years. So we're trying to get folks connected to them in that way.
Good afternoon, everyone. So I'm going to touch on a couple of the programs that the Northern Kentucky Health Department offers to help with the addiction and heroin response in Northern Kentucky. So I was asked first to talk about syringe access exchange programs. That, of course, is the hot button topic, oftentimes in the news and here in Northern Kentucky. So we have found, evidence has shown us that the increase in IV drug use, especially heroin, has led to an increase in, we've talked about all of these things. So drug overdoses, untimely deaths, ER visits, hospitalizations, babies born to women with drug addiction, arrest and other criminal activity, impact on businesses and economic development, and then where public health is mainly concerned are communicable diseases like hepatitis C. So what are we supposed to do? The health department in Northern Kentucky, we are the public agency that's charged with performing mandated public health services and addressing priority community health needs. So what we do is we prevent disease, we promote wellness, and then also protect against health threats. With regards to communicable disease control, we are under the authority of the cabinet to perform the duties of detection, prevention, and control of communicable diseases. So why should public health be concerned about IV drug use? Technically or typically that is not an area that health departments get involved in, but we have seen a role because sharing needles, syringes, and other drug equipment transmits disease, such as hepatitis C, hepatitis B, and HIV. And contaminated needles, syringes, and other drug equipment, they can get discarded in public places, and that puts the public and first responders at risk for diseases because of accidental needle sticks. So this is a look at hepatitis C in Northern Kentucky. On the far, I guess that's left-hand side of the map, you will see 2010 to 2015. That is what hepatitis C rates looked like in Northern Kentucky. As we've gone on down the line, that map has gotten darker. That's not a good thing. Red is not a good color in that map. That means our hepatitis C rates are going up. And at the bottom here, you can see this is the number of cases that we have of hepatitis C each year. 2010, we had 314, all the way up to 1,404 during 2017. You probably can't see it, but there's a little asterisk next to that. There's an asterisk because data sometimes lags, so we have 1,404 cases now. That number is likely to go up as time goes on. HIV. So as Amanda mentioned, we have 2 counties in the 4 counties that we serve as a health department that were on that list of 220 counties cited by the CDC as being at increased risk for an HIV outbreak, Grant County and Campbell County. Why we were cited as being at risk of an HIV outbreak was because we have a large number of drug overdoses, and we also have those very high rates of hepatitis C. And they have seen that those two things, especially when put together, have foreshadowed HIV outbreaks in other parts of the country. And we're starting to see that now. We're not in the middle of an HIV outbreak by any means. Our numbers are still low, especially compared with other parts of the country. But in 2016, we had 25 HIV cases. Only 5 of those were due to injection drug use as a risk factor. Typically, we see more sexual behaviors that are contributing to our HIV cases. However, in 2017, as of that should be March 29, 2018. We're still getting the numbers in. We had 45 cases of HIV, and 21 of those cases were due to injection drug use as a risk factor. Most of those cases have been in Kenton and Campbell counties, Covington and Newport. And that's our biggest concern, is that it's not an outbreak, but we are seeing a shift in risk factors, which means we need to respond differently when it comes to getting people into treatment. And then also preventing HIV from spreading. So Senate Bill 192, that's Kentucky's heroin law. That was passed in 2015, and that stated that local health departments could operate a syringe exchange program with the consent of the local board of health and also the government in the city and county in which it would operate. So what is a syringe access exchange program? It's a public health program meant to reduce communicable diseases. It exchanges sterile syringes, needles, and clean injection equipment for contaminated equipment, and also properly disposes of contaminated equipment. And what that does is it helps to get those needles, get that injection drug equipment out of public places, parks, wherever the case might be, and decreases the likelihood of accidental needle sticks with dirty needles. But there's so much more involved. I think sometimes where syringe exchange programs get a bad rap is because people think it's literally just that exchange of needles, but many more services are offered. And I thought that was on the next slide, but some of those services are offered. We always offer referrals to addiction treatment. So we have somebody from the Addiction Services Council at our Grant County Exchange Program that is there every week that program is running. So the minute the client or the patient comes in and says they want to get into treatment, they can walk them down to Hall and get that assessment and get that referral to treatment. We also offer vaccines. We offer connections to care. So if a nurse is looking, they can triage if there's some kind of issue going on, make sure that they get medical treatment, signing up for health insurance, WIC services, because a lot of our people that are injecting drugs, they have families, they may have jobs, they've got this whole life outside of that and are in need of other services. So it's not just that exchange of needles, it's so much more. So misconceptions and myths. Syringe access exchange programs do not encourage individuals to begin using drugs. They do not increase drug use among existing users, and they do not increase crime in neighborhoods where such a program operates. I'll get into in a second. I've got flyers back there, infographics of the 2 years that we've been in operation, our Grant County Syringe Exchange Program. And we are proud to say that we have never had to call police, call EMS for anything that has happened during that syringe exchange programs. It has not increased crime whatsoever. Those people that are attending that program, they typically want to stay under the radar because of what's going on in their lives, and they're going there to get help. They're not going there to commit a crime. There's often the kind of the pushback that, you know, people will say, well, you're giving out needles. Isn't that encouraging people to use drugs? Isn't that enabling them? We have seen that addiction is a disease, and people are going to use regardless of whether or not they have a clean needle. So oftentimes when people ask, well, is it enabling people? I say, yes, absolutely, it is enabling people. It is enabling people to live as healthy of a life as possible before they make that decision to get into treatment. It's enabling them to be a healthy person, to stay alive, because if they're not getting into treatment, and that's our ultimate goal.